This podcast is specially produced by the Critical Care Education Foundation's Knowledge Hub project for you, with the intention of providing a learning opportunity for doctors. It supplements the other material and self-assessments available on the CCEF Knowledge Hub project. Welcome to the Deep Dive. Today we are embarking on a crucial journey into central nervous system, CNS, infections. These aren't just any conditions. They are urgent, incredibly time-sensitive, and honestly, the landscape is shifting really rapidly. For us clinicians, staying truly current here isn't just about good practice. It's about making life-saving decisions. Our mission today is to, well, cut through the noise, extracting the most critical insights, and maybe some genuinely surprising facts from the latest research and guidelines, all specifically tailored for you, the medical professional.
Exactly. And this deep dive is, I think, vital, particularly because CNS infections present such complex diagnostic puzzles and therapeutic challenges.
Right.
What's truly paramount is rapid recognition and aggressive intervention. These are really the hallmarks for achieving optimal patient outcomes. You'll see that the field is really moving towards, precision medicine and advanced monitoring, which profoundly impacts how we approach these cases in the ICU.
All right, let's unpack this right from the start then with the initial assessment. What are those telltale clinical patterns that should immediately trigger a high suspicion for a CNS infection? And just how quickly do we need to react?
Well, when we look at clinical presentation, an acute syndrome, meaning symptoms developing in less than 48 hours, that really should be considered bacterial meningitis until you can definitively prove otherwise. That immediate mindset is absolutely critical.
Right. We often learn about the classic triad fever, neck stiffness, altered mental status. But here's a truly insightful takeaway from our sources. This triad, it's only present in about 44% of cases.
That's right. It's surprisingly low.
The real insight. A staggering 95% of cases will have at least two of these four: headache, fever, neck stiffness, or altered mental status. So it's not about waiting for that perfect textbook picture, is it? It's about having a broader diagnostic net.
Absolutely. You can't wait for the triad. And then you have the subacute or chronic presentation where symptoms might evolve over days, maybe even weeks.
Okay.
This pattern often signals something else: viral, fungal, TB, or even autoimmune causes. A gradual onset, especially if it's accompanied by focal neurological signs, should strongly point your thinking towards, say, encephalitis or maybe a brain abscess.
So when does that alarm bell truly ring for ICU admission? What are the specific criteria that mandate sending a patient straight into intensive care?
There are clear non-negotiable triggers for ICU admission. These include a Glasgow Coma Scale, or GCS, of 12 or less, any clinical or even subclinical seizures, any signs of increased intracranial pressure, or ICP, hemodynamic instability, respiratory compromise, or, of course, the presence of focal neurological deficits. Any one of these should prompt an immediate transfer to the ICU.
That brings us directly to the emergency management protocol, those time-critical actions needed, often within the first 30 minutes. What's the absolute priority here? The first things we must do?
The immediate assessment is everything. Vital signs, GCS, a thorough focal neurological exam, checking for signs of increased ICP like papilledema or new focal deficits. And don't forget that quick glance for a rash.
That's rash, right.
A petechial or purpuric one is a screaming red flag for a meningococcal infection.
And blood work. What's on the immediate must-do list? And what's the crucial sequence?
Your absolute priority, and this is key, is to draw 2 sets of blood cultures before you give any antibiotics.
Before. Always before.
Oh, always before. Beyond that, a CBC with differential, a comprehensive metabolic panel, coagulation studies, CRP, and procalcitonin are all essential. And, it's always wise to consider an HIV or hepatitis panel if the patient's status isn't known.
Now, the decision tree for neuroimaging.
Yeah.
Specifically, whether to get a CT scan of the brain before lumbar puncture. This could be a real point of contention in a busy ER, can't it?
Yeah.
When is that CT absolutely necessary and why?
A CT scan of the brain is indicated before an LP if your patient has a GCS of 12 or less, focal neurological deficits, new onset seizures, papilledema, is immunocompromised, or is over 60 years of age.
Okay.
These are all red flags for potential mass effect or maybe a lesion that could lead to herniation if you perform an LP without checking first.
Here's where it gets really interesting, and frankly, a point that just cannot be stressed enough. This is truly game-changing for patient outcomes.
Indeed. The single most crucial reminder, and really a rule to live by in this field, is to never delay antibiotics for imaging.
Never delay.
Empiric antibiotics must be started immediately after blood cultures are drawn. Don't wait for the LP results. Don't wait for the CT results. Time truly is brain here. Every minute counts in preventing devastating neurological damage.
So, we've drawn our blood cultures, acted swiftly with immediate antibiotics.
Yeah.
Now, let's dig into the specific empiric protocols for suspected bacterial meningitis. What's the go-to regimen for, say, a generally healthy adult under 50?
For that group, it's usually a combination of vancomycin, typically 15-20 milligram IV, and a third-generation cephalosporin like ceftriaxone or cefotaxime.
Right.
The specific dosing and target trough levels for Vanco will, of course, be guided by your local protocols and pharmacist input.
And if the patient is 50 or older or is immunocompromised, how does that change our empiric approach?
In those critical cases, you absolutely must add ampicillin to that regimen, usually 2 grams IV every 4 hours.
Right.
This ampicillin is crucial for covering Listeria monocytogenes, which is a significant concern in these specific patient populations. You just can't miss Listeria.
What about patients who've recently had neurosurgery or trauma or maybe have a CSF shunt? That introduces a whole different set of potential bugs.
Precisely. For them, it's still vancomycin, but now you'll add an anti-pseudomonal beta-lactam, something like ceftazidime, cefepime, or meropenem. You're covering for those resistant organisms often found in healthcare-associated infections.
And of course, we encounter patients with severe penicillin allergies.
hmm
What's the alternative empiric therapy then?
In that situation, meropenem is an excellent choice. Alternatively, trimethoprim sulfamethoxazole combined with vancomycin can be used.
Shifting gears slightly to empiric encephalitis, what's the standard immediate protocol there?
For all suspected encephalitis cases, a cyclovir 10 milliliter IV every 8 hours must be started immediately, no delay.
All cases, okay.
This is because herpes simplex encephalitis, HSV encephalitis, is just so devastating if untreated. If you also suspect a bacterial component alongside it, then you would add an age-appropriate bacterial meningitis regimen as well.
Let's not forget brain abscesses.
Yeah.
What does empiric therapy look like for those? It depends on the presumed source, right?
Yes, it does. If the source is unknown or metastatic, the regimen is typically vancomycin plus metronidase plus a third-gen cephalosporin like ceftriaxone.
Okay.
For post-neurosurgical or nosocomial cases, it's vancomycin plus ceftazidime, again with metronidazole. And if the source is dental or odontogenic, penicillin G plus metronidazole is often the recommended combination.
Now let's talk about adjunctive therapies, particularly corticosteroids. This raises an important question. When and how do we use them? What about the crucial timings?
Corticosteroids, specifically dexamethasone, play a very important role in bacterial meningitis. The protocol is a 0.15 milligrammi every 6 hours for 2 to 4 days.
Right.
Crucially, it must be given with or before the very first dose of antibiotics. That timing is absolutely key to its efficacy.
With or before the first dose. Got it.
The primary indication is suspected or proven pneumococcal meningitis in adults.
And are there specific scenarios where we should absolutely not give dexamethasone, even with suspected meningitis?
Yes, it's generally contraindicated in immunocompromised patients or if fungal meningitis is suspected. Clinically, though, dexamethasone significantly reduces mortality and decreases hearing loss and other neurological complications in pneumococcal meningitis.
Mm-hmm.
A point to remember for clinicians is that it may reduce vancomycin CSF penetration slightly, so monitoring those vancomycin levels is important. And, of course, if a non-pneumococcal organism is identified later, dexamethasone should be discontinued.
What about corticosteroids in other CNS infections beyond bacterial meningitis?
For myelitis, regardless of cause, methylprednisolone is typically used. For a brain abscess with significant edema, dexamethasone can be given, but really for the shortest duration possible.
Okay.
And use it with caution, as it might impair the abscess's encapsulation and potentially reduce antibiotic penetration into the abscess itself.
Let's quickly touch upon specific pathogen management. What are the unique or critical points for some of the most common culprits beyond the empiric treatment? For Streptococcus pneumonia, for example.
Right. For strep pneumo, if it's sensitive, you continue ceftriaxone. For resistant strains, it's vancomycin plus ceftriaxone, usually for 10-14 days. And always remember, give dexamethasone with S. pneumoniae meningitis.
Always with pneumococcus.
Yeah.
And Neisseria meningitidis. What's critical for public health here?
Neisseria meningitidis is treated with penicillin G or ceftriaxone for about 7-10 days. The crucial public health aspect is droplet precautions for 24 hours after starting effective antibiotics and contact prophylaxis for close contacts, usually with ciprofloxacin.
Listeria monocytogenes. I recall something specific about cephalosporins not working here.
You're exactly right. Listeria needs ampicillin, often paired with gentamicin, for at least 21 days. The key point is that cephalosporins have no activity against listeria, so ampicillin is absolutely non-negotiable if listeria is suspected or confirmed.
Good reminder. And finally, for HSV encephalitis.
HSV encephalitis is managed with acyclovir 10 milligram of tulogram IV every 8 hours for a good duration, 14-21 days, and always remember to adjust the dose carefully for renal function. Okay, let's shift our focus now to the intensive care unit. What's truly fascinating here are the advanced management strategies for complex complications like increased ICP and seizures. These can really make or break a patient's outcome.
Yes, managing increased ICP is just foundational to neurocritical care, isn't it?
Yeah.
What are the immediate first-line measures we should be implementing in the ICU?
Well, the first-line measures for increased ICP include elevating the head of the bed to 30 degrees and carefully maintaining PaceO2 between 35-40 millimole Hg. This means avoiding aggressive hyperventilation unless absolutely necessary as a bridge.
Right.
We also need to target a mean arterial pressure, or MAP, of 80-90 millimole Hg, aiming for a cerebral perfusion pressure, CPP, greater than 60 millimole Hg. Sedation, often with propofol or midazolam plus fentanyl, is also key to reduce metabolic demand.
And what about hyperosmolar therapy like mannitol or hypertonic saline? When do those come into play?
For hyperosmolar therapy, mannitol can be given, say, 0.25 to 1 g kilogram IV every 6 hours, targeting a serum osmolality below 320 minosm kilogram. Alternatively, 3% hypertonic saline, maybe 250-500 milliliter IV over 10-20 minutes, is another potent option, and some prefer it for a more sustained effect.
Are there more advanced measures for ICP management if those first lines aren't enough?
Yes, if initial measures are insufficient, we consider CSF drainage, often with a lumbar drain if there's no mass effect and no risk of herniation.
Okay.
ICP monitoring itself is indicated if the GCS is 8 or less, and in truly refractory cases, decompressive craniectomy might have to be considered as a last resort.
Let's move to seizure management. What are the immediate steps in the ICU, and what if seizures persist into status epilepticus?
For immediate seizure control, lorazepam or midazolam are your first-line benzodiazepines. Quick acting. If seizures persist, second-line options include phenytoin or levetiracetam.
Levetiracetam seems more common now.
It often is due to fewer interactions and easier dosing. For status epilepticus, we follow a step-by-step protocol. Continued benzos, then a second-line agent like phenytoin or levetiracetam, then considering valproic acid or lacosamide. For super refractory cases, continuous infusions of propofol, midazolam, or even pentobarbital might be needed.
I understand continuous EEG findings are quite significant here, often revealing hidden seizure activity, right? Non-convulsive status.
They absolutely are. Continuous EEG monitoring is critical because non-convulsive status epilepticus is surprisingly common. It's present in about 30% of CNS infection cases in the ICU.
Wow, 30%.
Yes. So a minimum of 24-48 hours of monitoring is generally recommended if there's altered mental status. And it's important to note that early seizures, convulsive or not, are a predictor of worse outcomes.
And for hemodynamic support in these critically ill patients, especially with sepsis.
If septic shock is present, we follow the standard septic shock protocol. Fluid resuscitation, and norepinephrine as the first-line vasopressor to target a MAP of 65 millimole Hg or higher. Maybe even higher if there's increased ICP to maintain that CPP. Hydrocortisone should be considered for refractory shock.
Building on that ICU care, brain abscess management has its own specific surgical considerations. When is urgent surgical intervention truly indicated for a brain abscess?
Surgical intervention is generally considered urgent if the abscess is larger than 2.5 centimeters in diameter, or if it's located in the posterior fossa regardless of size, because that space is tight and the risk of herniation is high.
Okay.
Also, if there's ventricular rupture or it looks like it's about to rupture, clear signs of increased ICP, failure to improve clinically after 48-72 hours of medical therapy, or in cases of multiple abscesses that are surgically accessible.
What are the key preoperative stabilization steps for these patients heading to the OR?
Preoperative stabilization involves dexamethasone, usually to reduce edema, mannitol if there are acute signs of herniation, and phenytoin loading for seizure prophylaxis is common practice. It's also vital to ensure adequate antibiotic levels are achieved before surgery if possible. Post-operatively, it's all about meticulous neurological checks, follow-up imaging to ensure resolution, monitoring for complications, and of course, continuing antibiotics based on culture results, often for a long duration.
One critical area where CNS infections present truly unique challenges is in immunocompromised patients, particularly those with HIV/AIDS. How does a patient's CD4 count guide our risk stratification for these vulnerable patients?
The CD4 count is absolutely crucial for risk stratification. If it's above 500, you'll generally see the standard bacterial pathogens and maybe TB. Between 200 and 500, HIV-associated neurocognitive disorders become more prevalent. But it's really below 200 where the big risks for opportunistic infections emerge: toxoplasmosis, cryptococcosis, CMV, PML, and the risk escalates even higher below 100, particularly below 50, where CMV, MAC, and PML become major concerns.
What's the management protocol for toxoplasmosis, given it's a common opportunistic infection in this group?
For toxo, which often presents with those characteristic ring-enhancing lesions on imaging and positive serology, the first-line therapy is sulfadiazine plus paramethamine plus leucovorin to prevent bone marrow suppression.
Right, the leucovorin rescue.
Exactly. If there's a sulfa allergy, clindamycin replaces sulfadiazine. You should typically see clinical improvement fairly quickly, within about 3 to 7 days.
And for cryptococcal meningitis, I know checking opening pressure is critical here because of the risk of elevated ICP.
Absolutely. Always check the opening pressure on LP. The induction phase for cryptomeningitis involves liposomal amphotericin B plus flucytosine for at least 2 weeks. This is followed by a consolidation phase with fluconazole for 8 weeks, and then a maintenance phase, usually lifelong fluconazole, or at least until the CD4 count recovers significantly for a sustained period.
And managing that high opening pressure.
For elevated ICP, daily therapeutic LPs are often performed until the pressure normalizes. A lumbar drain might be considered in some cases, and acetazolamide may also be helpful adjunctively.
What about CMV encephalitis and progressive multifocal leukoencephalopathy, or PML? These can be devastating diagnoses.
Yes, they can. CMV encephalitis is typically treated with ganciclovir, often combined with foscarnet initially for severe cases. For PML, unfortunately, there's no specific direct antiviral treatment effective against the JC virus.
So what's the focus then?
Management really focuses on immune reconstitution by optimizing the patient's highly active antiretroviral therapy, or HART, and providing intensive supportive care. This really raises an important question about how we diagnose these more elusive infections, especially when conventional methods like cultures fall short. And here's where we've seen some truly landmark diagnostic breakthroughs recently. I'm talking about metagenomic next-generation sequencing, or MNGS.
Ah, yes, MNGS. It's certainly been a potential game changer. What did that big NEJM multi-center study from 2019 really show us? What was the big takeaway for clinicians?
That study, a prospective trial across 8 centers, was quite impressive. It found that MNGS identified an additional 22% of pathogens that standard conventional testing simply missed.
42% more. That's significant.
It really is. And what's crucial for you in practice is that 8 out of the 13 unique diagnoses identified only by MNGS led to significant, often life-saving treatment changes. The take-home message was clear. MNGS should be strongly considered for unexplained meningoencephalitis when standard tests are negative. It significantly enhances diagnostic yield.
And more recently, the 7-year UCSF clinical performance study from just this year, 2024, provided even more comprehensive data, didn't it?
Yeah.
What did this larger study confirm about MNGS's clinical impact?
This was a massive study looking at over 4,800 CSF samples. It demonstrated an overall positivity rate of about 14.4%, with DNA viruses being the most common pathogens detected. Its clinical impact was substantial. It identified almost 22% of infectious diagnoses solely by MNGS.
Wow.
And here's why that's so powerful. Its specificity was incredibly high, 99.6%, meaning false positives are extremely rare. This gives us immense confidence to act on positive results from MNGS.
So, practically speaking, how do we best integrate MNGS into our clinical workflow? What are the key guidelines for optimal use? When should we be thinking about ordering it?
Well, the optimal timing for sending the sample seems to be within 24 or 48 hours of admission, if possible. You need a minimum CSF volume, usually 0.5 to 1.0 milliwelt. From a cost-effectiveness standpoint, it's probably best considered for those culture-negative cases or atypical presentations where you're really struggling to find a diagnosis after standard testing.
And the turnaround time?
The turnaround time for results is generally quite rapid now, often within 24-48 hours, which is fantastic for potentially guiding therapy quickly.
Beyond just identifying the pathogen, precision medicine applications are also advancing. What are some of the key biomarker developments that help us distinguish between different CNS infection etiologies, like bacterial versus viral?
CSF lactate levels are a strong biomarker. A level above 4.5 millimole very strongly suggests a bacterial etiology with over 90% specificity.
Okay, lactate 4.5.
Yes. Procalcitonin, the serum marker, is also helpful in differentiating bacterial from viral causes, generally higher in bacterial infections. Additionally, inflammatory biomarkers in CSF, like IL-6 and TNF-alpha, can sometimes correlate with severity and outcomes, though they're less commonly used for routine diagnosis.
And what about pharmacogenomics? How's that starting to play a role in treating CNS infections?
Pharmacogenomics, specifically looking at things like CYP2C19 variants, is particularly relevant as it affects the metabolism of certain antifungals, like voriconazole, used in fungal CNS infections. Understanding a patient's genetic profile here can potentially help guide individualized therapy and prevent toxicity, especially for those prolonged antifungal regimens.
Beyond what we've considered standard infections, new clinical entities and groundbreaking study findings are genuinely reshaping our entire approach to CNS infections. One significant and frankly quite novel entity is COVID-19 CNS complications. What are the key epidemiological insights we've gained here?
The epidemiological data has shown that about 30% of hospitalized COVID-19 patients develop neurological symptoms. And critically, the presence of these CNS complications significantly increases their ICU mortality risk by maybe 2 to 3-fold. It's a serious issue we now have to regularly consider.
What does the clinical presentation spectrum look like for these patients? It seems quite varied from what I've read.
Indeed, it is. The most common symptoms are consciousness disturbance, affecting nearly 60% of those with neuroinvolvement and seizures, seen in about 22%. More severe forms include things like acute hemorrhagic necrotizing encephalopathy. And concerningly, long-term cognitive impairment, even resembling Alzheimer's-like pathology, has been observed in some survivors.
How do we diagnose COVID-19 related CNS issues, especially since respiratory samples might be negative? This sounds like a real diagnostic challenge sometimes.
Yeah, it absolutely is. The diagnostic approach includes looking for SARS-CoV-2 RNA directly in the CSF. It can be detectable there even when nasopharyngeal swabs are negative, so don't rule it out just based on a negative nasal swab.
That's key.
Imaging may show characteristic changes, like hyperintensity in the temporal lobes and hippocampus, although findings can be variable. EEG findings often reveal patterns like monomorphic delta waves, sometimes with myoclonic activity, which unfortunately tends to be a poor prognostic sign.
What's the recommended treatment protocol for these complex cases?
The treatment protocol generally involves your standard meningoencephalitis workup, plus sending SARS-CoV-2 PCR on the CSF. Empiric acyclovir and antimicrobials should still be started promptly as per guidelines for other causes. Additionally, for suspected immune-mediated cases, considering steroids, plasma exchange, or IVG is important. The crucial takeaway for clinicians: always consider COVID-19 CNS infection in any patient presenting with altered mental status during or after COVID, even if the respiratory samples are negative.
The Eureka study, published in 2023 on ICU outcomes in severe CNS infections, sounds like a truly landmark study, giving us some really actionable data. Can you tell us more about its scale and the key mortality findings?
The Eureka study was indeed landmark. It was conducted across 68 ICU centers in 7 European countries, involving adults with severe meningoencephalitis requiring ICU care. Its key mortality findings were, frankly, quite sobering. An overall ICU mortality of 25.8% and hospital mortality of 35.3%, and high rates of significant disability at 3 months among survivors.
Those are high numbers. What were the most actionable risk factors identified from this study? Things that we as clinicians can directly influence.
The study highlighted several critical, actionable risk factors. Delayed ICU transfer was a major one. Each hour of delay significantly increased mortality risk.
Every hour counts.
Exactly. Similarly, antimicrobial timing was paramount. A delay of more than 2 hours from presentation to the first antibiotic dose basically doubled the mortality risk for bacterial cases. It just powerfully underscored the critical importance of speed.
And what were its practice-changing recommendations based on these findings?
The recommendations were incredibly clear and practical. Early ICU transfer should be considered for any CNS infection patient with a GCS of 13 or less. Don't wait until they're crashing. There's now a strong target for antibiotic administration. Less than 60 minutes from presentation for suspected bacterial cases.
Under an hour.
Under an hour. And finally, a monitoring bundle, including continuous EEG and ICP monitoring when indicated, should be implemented proactively to catch complications early. This study truly emphasizes that every single minute counts in management. Let's connect this now to the broader picture of evolving treatment paradigms, thinking about updated antimicrobial approaches and advanced neuromonitoring. What's new and changing in these areas based on recent evidence?
What are the key updates in antimicrobial approaches, especially for, say, healthcare-associated ventriculitis, or those challenging resistant organisms we sometimes face?
Well, for healthcare-associated ventriculitis and meningitis, HAVM, empiric therapy typically involves vancomycin plus an anti-pseudomonal agent like cefepime, ceftazidime, or meropenem. For resistant organisms, if you're dealing with MRSA with a high vancomycin MIC, we now consider alternatives like linezolid or possibly ceftaroline. For carbapenem-resistant Enterobacteriaceae, or CRE, newer agents like ceftazidime avibactam or meropenem vaborbactam are becoming crucial options, often guided by infectious disease specialists.
And durations.
Durations are typically at least 10-14 days, often longer, sometimes 21 days or more, for complicated cases like ventriculitis or abscess.
What about advancements in ICP and seizure management within neuromonitoring?
Mhm.
Are there preferred agents or strategies emerging from recent studies or guidelines?
In ICP management, as we touched on, 3% hypertonic saline is increasingly preferred by many over mannitol for a potentially more sustained effect, though both are used. Lumbar grains are certainly a growing strategy for select cases without mass effect to help manage ICP and hydrocephalus. For seizure management, levetiracetam is now often preferred over phenytoin as a second-line agent, mainly due to its favorable side effect profile and fewer drug interactions. Lacosamide is also emerging as another good second or third line option. And for super-refractory status epilepticus, ketamine infusions are gaining traction as a potential option alongside the traditional anesthetic infusions.
We're also seeing a growing recognition of autoimmune encephalitis, aren't we?
Yeah.
How frequently is this actually being encountered now, and what's the updated approach to diagnosis and management?
Yes, autoimmune encephalitis is now recognized much more frequently, maybe in 20–30% of what used to be classified as culture negative or idiopathic encephalitis cases. This necessitates using expanded antibody panels for diagnosis.
Right, those panels are key.
The treatment protocol generally involves first-line high-dose methylprednisolone, followed by IVG or plasma exchange as second-line options if needed, and rituximab often considered as third-line for refractory cases. The critical insight here is early recognition and not delaying immunosuppression while waiting for antibody results, especially if clinical suspicion is high. Delay can lead to irreversible neurological damage.
What about the updated WHO guidelines for drug-resistant tuberculosis CNS management? That can be notoriously difficult to treat.
Yes, drug-resistant TB meningitis is a huge challenge. The updated 2022 WHO guidelines recommend a preferred first-line regimen that includes drugs like bedaquiline, linezolid, levofloxacin, and cycloserine or taururzidone. The duration is very long, a minimum of 18–20 months. And steroids, like dexamethasone, also play an important role in reducing inflammation, similar to drug-sensitive TB meningitis.
And finally, are there any emerging therapeutic targets we're seeing on the horizon? Things that could change how we treat these infections in the future?
There are some interesting developments. Emerging targets include more specific anti-inflammatory strategies, things like anakinra, an IL-1 receptor antagonist, or tocilizumab, an IL-6 receptor antagonist, being explored for severe or hyperinflammatory states, particularly in refractory cases or specific etiologies. Also, novel antifungals like isavuconazole and the investigational agent olorifim are showing promise for difficult-to-treat or resistant mold infections, which could expand our limited arsenal there.
As we bring this deep dive towards a close, let's talk about what success looks like, how we monitor patients closely, and maybe reiterate those truly critical reminders every ICU team needs to keep top of mind. What are the key performance indicators for quality measures and outcomes in CNS infections?
Key performance indicators, things we should be tracking, include time to first antibiotic dose, aiming for less than 60 minutes in over 90% of bacterial cases. Appropriate empiric antibiotic coverage initiated within 6 hours. Dexamethasone administered with or before the first antibiotic dose in over 90% of suspected pneumococcal cases. Blood cultures drawn before antibiotics in over 95% of cases. And lumbar puncture performed within 2 hours of presentation, unless it's clearly contraindicated by risk of herniation. These are really your targets for best practice delivery.
What are the most significant prognostic factors associated with poor outcomes? The things we should be particularly vigilant for when assessing a patient?
Poor outcomes are strongly associated with advanced age, significant underlying comorbidities, a low GCS on admission, the presence of seizures at presentation, abnormal neuroimaging findings like edema or stroke, a high CSF bacterial load if measured, and crucially delayed initiation of appropriate therapy.
And mortality rates, they vary a lot, don't they?
They do vary significantly by pathogen. For example, S. pneumonia meningitis still carries a mortality range of roughly 16–37% depending on the study and population. Untreated HSV encephalitis has a mortality rate historically as high as 70%, which dramatically reduces to maybe 10–20% with timely acyclovir treatment, so early, correct treatment is paramount.
How do we monitor these patients closely in the ICU, and what are the critical complications we need to watch for and manage proactively?
Neurological monitoring should be frequent, often hourly initially, including pupillary checks and GCS. Continuous EEG is vital if altered mental status persists or if seizures are suspected. Laboratory monitoring includes daily CBC, BUNCR, electrolytes, and perhaps twice-weekly LFTs, along with relevant drug levels like vancomycin.
Yeah, and complications.
Key complications include hydrocephalus, which might require an external ventricular drain, EVD, or other CSF diversion. Cerebral edema and herniation demand immediate intervention. Mannitol, hypertonic saline, possibly temporary hyperventilation, head of bed elevation, and always urgent neurosurgical consultation. SIADH leading to hyponatremia is common and requires careful fluid restriction, maybe hypertonic saline for severe symptomatic cases, correcting slowly. Regarding specific ICU protocols, mechanical ventilation should generally be lung protective. Target PaCO2 carefully, usually 35–40 millimilli Hg, avoiding aggressive hyperventilation unless managing acute herniation. Propofol is often preferred for sedation due to its short half-life. And norepinephrine is the first-line vasopressor for hemodynamic management and associated septic shock.
And finally, for antibiotic duration and monitoring response, what are the typical expectations and what do we do if the patient isn't improving?
Typical antibiotic durations vary: 7–10 days for H. influenza and N. meningitis, 10–14 days for S. pneumonia, and a minimum of 21 days for L. monocytogenes. Brain abscesses often require a much longer course, maybe 6–8 weeks of IV therapy, sometimes even longer, potentially extending to 12 weeks depending on response and imaging. Clinical improvement should generally be noticeable by 48–72 hours. If there's no improvement or if the patient worsens, a repeat LP, repeat MRI, and definitely an infectious disease consultation are mandatory to reassess the diagnosis and treatment plan.
Lastly, any prophylaxis protocols we should remember for close contacts of patients with specific CNS infections?
Yes, briefly. For close contact prophylaxis against meningococcal exposure, ciprofloxacin is commonly used as a single dose for adults. Ceftriaxone is an option, especially for pregnant women. Rifampin is another alternative but requires multiple doses. For Haemophilus influenza type B exposure in unvaccinated close contacts, rifampin is given for 4 days. Okay, let's try and distill this wealth of information to the most critical reminders for ICU teams. These are the absolute don't miss points that can genuinely save lives and prevent disability.
The take-homes.
Exactly. Firstly, and we've said it before but bears repeating, never delay antibiotics for LP or imaging. Time is critical. Secondly, start dexamethasone with or just before the first antibiotic dose in all cases of suspected pneumococcal meningitis in adults. Don't give it later.
Got it.
Thirdly, give acyclovir immediately for all suspected encephalitis cases, regardless of other initial findings, to cover for HSV.
Right.
Fourthly, implement droplet isolation until 24 hours of effective antibiotics have been administered for suspected bacterial meningitis.
Okay, infection control.
Fifth, remember that LP is generally contraindicated. If there are signs of significantly increased ICP or mass effect on imaging, get a CT first, but again, do not delay the antibiotics while waiting for that CT.
Crucial balance.
And finally, a brain abscess greater than 2.5 centimeters or one in the posterior fossa generally requires urgent surgical consultation. Don't sit on those. Also, always be mindful of important drug interactions like phenytoin potentially decreasing dexamethasone levels or the potential for reduced vancomycin CSF penetration with dexamethasone. And of course, always ensure appropriate renal dosing adjustments for renally cleared drugs.
We've truly gone on a deep dive today into the complexities of CNS infections, from the nuances of time-critical interventions all the way to cutting-edge diagnostics like MNGS and novel therapies. It's abundantly clear that vigilance, speed, and a precise understanding of this rapidly evolving landscape are absolutely paramount in improving patient outcomes.
Indeed. The Eureka study profoundly underscored how every single hour counts in the early stages. And innovations like MNGS, coupled with our evolving understanding of autoimmune etiologies, are genuinely transforming how we approach diagnosis and patient care. This really raises an important question for you, the listener, to ponder.
Hmm.
How will these advancements, particularly the faster integration of rapid molecular diagnostics like MNGS, reshape your immediate approach to managing a patient with suspected CNS infection in your practice over the next 6 months? How will it change what you do in those first critical hours?
That's a great question to reflect on. Thank you for joining us on this vital deep dive. Keep exploring, keep learning. We hope this has provided you with actionable insights to truly enhance your practice.